Okay, this is NG tube insertion, and I'm going to begin by reviewing the order for the NG tube and then medical history regarding deviated septums and nasal surgery histories. And then I'm going to gather my equipment, which I have right here, and then perform my hand hygiene. Then I'm going to identify the patient with the two patient identifiers, so have them tell me their name and birth date, then check out their name band, make sure it matches, and compare with the MAR too, and then provide privacy by bringing the curtain around. And then assess the patient's mental status, so I'm going to ask them test their person, place, and time, and explain the procedure to the patient. So we'll be sticking the NG tube up through the nares to the back of the throat, called the pharynx, and then all the way down to the stomach. And then establish a stop sign with the patient. So at any point during the procedure, when you feel like you need to stop, just raise your hand and give me the stop signal. And then I'll perform an abdominal assessment. Check out the patient's abdomen, look for any signs of distension or anything of that nature, and auscultate for vowel sounds. 2 minutes in each quadrant. Go around. And also palpate in each quadrant for any masses or tenderness or any abnormalities. Then I'm going to assess the nares for any skin breakdown and for the patency of the nares as well. Then the bed's already raised, but I would raise the bed to high Fowler's position, which you probably raise a little bit more. And should I say it? I'd say it's already high Fowler's. And then and drape their chest with a disposable pad or towel. Just got the disposable pad for now. And now I'm going to don my gloves. Okay. I'm going to take the tube out of the package. I'm not going to open these just for the purpose of the video, but I'd break open my lube, squirt that down to my little basin I got going here, and then measure the tube from the tip of the nose to the earlobe to the top of the xiphoid process. And now that I have that length, I would mark the tube with a marker and then lubricate 2 to 4 inches of the tube with the lubricant. I put in here. Then instruct the patient to tilt their head back on the pillow. So they do that, and then I enter gently and say, once I reach the back of your throat and you feel it hit back there, just give me the stop sign. And I insert 1 to 2 inches at a time. Once they give me the stop sign, I tell them then to bring their head forward and tuck their chin just slightly and swallow the tube. Keep on trying to swallow the tube as I advance it 1 to 2 inches. So the tube didn't go all the way down to the mannequin, but I'll just bring it all the way to the marked site I made. And once I do that, get my tape. Zoom in a little bit, come in a little bit. Get my tape under the nares, cross it over so it's secured on the nose. Zoom in on that a little bit. So just cross it over underneath. Okay, you can come back out now. Okay, now immediately when I do that, I'm going to check my placement first by looking at any signs of respiratory complications. And where's my... Let me see that real quick. Can you grab that syringe and it's over there, the syringe and measuring cup.
Where's that? Syringe and measuring cup.
Okay. So, and then it says for any respiratory complications such as coughing, which would indicate it's in the lungs and not the stomach. There's none of that going on, so now I can aspirate the stomach contents just a little bit. Kink that and drop that on one of these. Come here a little bit. Drop the stomach secretions on a little bit of the pH pad right there. And then if I have any leftover secretions, unkink the tube, and then return that to the patient. So now that I've done that, and the pH, if it's 0 to 4, that indicates gastric placement, and if it's 6 and above, that indicates lung or intestinal placement. And I'm also going to be looking at the color and consistency as I pull that aspirate out as well. And now to finally confirm the placement of the NG tube, I'm going to get an x-ray for them. And if I have to leave and come back, I'm just going to repeat the same process and look at the aspirate and the respiratory complications to make sure it's still at the correct side along with the tube marking I made. So once the x-ray has been done, I come back and verify that the tube marking is still where I left it. And I don't have a measuring device right now on me, but I would measure the amount of tube that I have exposed. And also for NG tubes that were placed in gastric surgery, I would not reposition them or position them at all, or else that could rupture the suture lines in the stomach. And now once I've done that, going to clamp the tube, clamp it, and remove my syringe, and then either cap the line or connect it to suction. And once I've done that, I can provide oral care with any swabs I have handy. Right now, for the purpose of this video, I don't have any, but provide oral care, and then clip the tube to the patient's gown. And then position the patient back into a position of comfort and lower the bed no more, no less than 30 degrees. Take off my gloves, discarded them, perform hand hygiene, and document the procedure.